Hello everyone. Now today we will be discuss about renal tumor. Okay, and in renal tumor there are the 5 topics that we need to know clearly because there will be a question on board. Okay, and these are high yield as well. So what are the 5 main thing is renal cell carcinoma, that is RCC, renal oncocytoma, then we will discuss about Wilms tumor, then we will discuss about transitional cell carcinoma, and then squamous cell carcinoma. So these are the tumors of renal system, and so we have at least by heart these 5 topics. Okay, so this all thing what I have written here is in your first aid book. You just need to understand, or you need to have a path to remember it so that you can match the question very easily. Okay, so let's begin from our renal cell carcinoma. Since renal cell carcinoma, there is one way to remember that it is a RCC, renal cell carcinoma, that is a 3 word, and since it is a 3 letter, and since it is a 3 letter, then it is easy to remember that it is the chromosomal deletion or in the chromosome number 3. That is the one important point. Okay, so one of the features that you have to know is that it is a chromosome number 3, where there is a deletion, and that has led to the renal cell carcinoma. And the site of renal cell carcinoma origination is from proximal convoluted cell. That proximal convoluted tubule cell is the site where renal cell carcinoma originates. Okay. Then let's comes to the tumor. Now tumor has, you know, the origin of the cell. Now let's come to the gross appearance. When you autopsy the patient, or when you do the surgery and bring it out and see on a gross examination, just with naked eye examination, you will find that there will be the golden yellow color. There is a picture in first aid. You go and see there will be the golden yellow color. Okay, and it is due to the increased lipid content. Okay, so when you see the tumor, then there will be a slight change the color from your normal tissue, and that will be golden yellow. Okay, then coming to the histology, when we resect it, process it, and see on the histological slide under the microscope, then we'll find that the polygonal clear cell filled with accumulated lipids and carbohydrate. So there is a picture again in the first aid. You go and see that there will be the polygonal clear cell filled with accumulated lipids and carbohydrate. And since this is the actually a way of diagnosed even in the real scenario as well. When you see there will be the patient present with the history, then you go for the origination of the cell, then there will be the gross examination of the tissue, and there will be the histological examination. So this 3 thing is important for your diagnosis. Okay, then comes to it is more common. Then it is more common in the men. 50 to 60 years is the mean peak age of having renal cell carcinoma. Okay, incidence increase with smoking and obesity. Okay, then what are the presentation? Presentation will be like there will be a flank pain, palpable masses, hematuria, fever, weight loss, and secondary polycythemia. So presentation is quite simple, that a patient having tumor into the kidney, then there will be what? There will be the palpable mass. He may experience the flank pain. Since this is a tumor, there will be a painless hematuria. Okay. Then there might be a fever and weight loss. And since this is a renal cell carcinoma, there is a ectopic secretion of erythropoietin. We'll talk about it. And because of that, it will lead to the polycythemia, secondary polycythemia. Okay. Now let's move to the metastasis. Look, when a renal cell carcinoma occurs, then it will invade the renal vein as well. And since in right side it directly drains into the inferior vena cava, but in the left side, the left gonadal vein come into the left renal vein and then drain into the inferior vena cava. So if renal vein is involved, then there will be the left gonadal varicose will also develop. That is important. Okay. So, and event then comes to the inferior vena cava, and then hematogen will spread and comes to the lung and bone. So this is the way of metastasis. Okay. Then what will be the treatment? Our treatment will be a surgery and ablation for localized disease. If it is a localized disease, then what we'll do? We'll do the surgery and ablation. But if it is a metastasis disease, then we can try for immunotherapy, that is a adesileukin, okay, or targeted therapy for metastatic diseases, but it is rarely curable. Okay, it is resistant to radiotherapy and chemotherapy. So this is pretty tough to manage, tough to cure actually. So if it is a localized, we can remove it, but if it become metastasis, then it becomes very difficult to treat. Okay. Now, this is the most common primary renal malignancy and associated with the paraneoplastic syndrome. And what are the paraneoplastic syndrome? These are the syndrome where you will find that ectopic secretion of your hormones that has led to the secondary changes. Like there will be the ectopic secretion from the erythropoietin. Okay, normally erythropoietin is secreted from your kidney, but now there will be ectopic site. Okay, there will be ectopic secretion of acetyl. There will be ectopic secretion of parathermal reverse protein. There will be ectopic secretion of renal. And because of that, there will be a lot of consequences in your body according to the hormone. If there is ectopic erythropoietin, you will have secondary polycythemia. If you have ectopic renin, there will be the hypertension. Okay, so these are there will be the calcium related imbalance, acidosis. This all will produce the symptoms in the patient as well. Okay, so this is renal cell carcinoma. It is a carcinoma, that is metastatic disease, that you have to understand. In contrast to this, there is another term known as the renal oncocytoma. Okay, so we are talking about renal oncocytoma, and it is a benign. That was a malignant. It is a benign tumor that is originated from the PCT, that is proximal convoluted tubule, but it will originate from the collecting duct. That is different. Origination is different. That is with malignant. This is benign only. Then again comes to origin, you have then gross appearance. Gross appearance, there is a clear picture in your effect that there is a well circumcised mass with the central scar. So if you see the picture, then there is a well circumcised, and in the center there is a scar, white appearance. So well circumcised. This is very really well circumcised, and in the mid there will be the white scar. Okay, so this is well circumcised mass with central scar. On histology, when you process and examine under the microscope, then there will be the large eosinophilic cell with abundant mitochondria without perinuclear clearance. That you need to understand. Okay, so gross appearance you have understood. When you examine histology, what is the characteristic finding? There is a large eosinophilic cell with abundant mitochondria without perinuclear clearance, and that is differentiate from your chromophobe renal cell carcinoma. That is versus there will be a different picture. So renal oncocytoma, benign tumor, arise from the epithelial tumor, arise from the collecting duct. On gross appearance, there is a well circumcised mass with the central scar. Okay, on histology, there will be the eosinophilic cell with abundant mitochondria without perinuclear clearing, and the presentation will be since it is tumor, there will be the pulpal mass, pelvis hematuria, flank pain, and abdominal mass. This will be the presentation of your patient. Okay, so that is important, and it needs to be actually occasionally, most of the time it is removed because of the risks of the malignancy or to exclude the malignancy. Okay, sometimes we need to exclude the malignancy, for also we remove it surgically and then examine. If it is renal cell carcinoma, then we have to search for the metastasis like to the bone along, because it may be involved, and then accordingly we have to manage. If it is a benign only, then there is no much problem, we have removed it surgically. Okay, so hope this is helpful. Now we will go to the next lecture, and we will discuss about Wilms tumor, transitional cell carcinoma, and squamous cell carcinoma. Okay, thank you.